Hi everybody, thanks for joining us here on Optometry TV. I'm Kara Moore, joined now by Dr. Nicholas Colatrella. Thanks for being here. And Dr. Jeffrey Varanelli.
Thank you.
Good morning to both of you.
Good morning.
Okay, so let's talk about the advances in the management of neurotrophic keratopathy. And I know that you said this was sort of something that was near and dear to you.
Yes, yeah. Well, thank you for the opportunity to be here today. And this is something that's near and dear to our hearts, ocular surface disease. Specifically, neurotrophic keratopathy is one of the most refractory corneal disorders that we can deal with as clinicians. And it's been a known disease entity since the early 1800s when they noticed some type of disruption in the trigeminal nerve created a loss of corneal sensation. And that led to superficial punctate keratopathy, persistent epithelial defects, even corneal melts and corneal perforation. So it can be quite challenging to diagnose and manage these patients, and oftentimes we find that it goes underdiagnosed and even misdiagnosed as dry eye and herpetic disease.
And is that a little bit about your lecture? Is that sort of a preview of
Yeah,
what your
and
lecture's about?
the benefit of the lectures, there's new novel medical and surgical therapies that we go through. We talk about the biologic therapies that use allogenic and autologous serum, amniotic membrane therapy, and the first-in-class recombinant human nerve growth factor with synedromin BKBG that allows us to treat these patients in ways we've never had the opportunity to before.
So how is this diagnosed?
The cornea is arguably the most sensitive structure in the human body. It's 40 times more sensitive than dental pulp, 100 times more sensitive than the conjunctiva, and 400 times more sensitive than the skin. So, we have to assess corneal sensation in one way, shape, or form. And that's really where we're noticing it's being underdiagnosed because we're not testing corneal sensation as often as we should. So whether it's qualitative measures such as a cotton wisp or dental floss, or a more quantitative measure using the Coquet-Bonnet esthesiometer, we have to have some type of corneal nociception and test corneal sensitivity.
And now that we talked a little bit about how it's diagnosed, Dr. Varanelli, talk about symptoms that patients may come in with for practitioners to look out for.
Sure, and it's interesting because early on in the disease, these patients might actually come in with some symptoms of dry eye. So it might be foreign body sensation, it might be sensitivity to light, it might be, these symptoms can actually be maybe exacerbated by staring at a computer or by force moving air from a ceiling fan or vents in a car. So things that we can initially think about for a dry eye patient, we always have to keep in the back of our mind, especially if there's other signs that we see clinically or through their history, that neurotrophic keratopathy can actually be an issue as well. But, paradoxically, later on in the disease, so as we get to the more advanced and severe stages, these patients actually don't come in with a symptom of pain. They actually come in with a symptom of blurred vision. So those are things we have to keep in mind as we kind of go through the history, go through the clinical examination. And as Nick said, these patients are probably underdiagnosed or misdiagnosed. So we have all these different steps in place to really make that correct diagnosis.
And once you make that correct diagnosis, what about the treatment?
Treatment can be challenging. And I think first and foremost, we have to look at some of the things that can contribute. We do know that certain topical and systemic medications, some neuroleptics, antipsychotics, antihistamines, long-term chronic use of those can actually lead to some symptoms of neurotrophic keratopathy. But then we also look, does inflammation play a role? If it does, we need to worry about treating inflammation, but being carefully on with certain topical medications that can create some issues on the cornea as well. But ultimately, treating early on in the phases, treating the dry eye symptoms, the surface issues, so preservative-free artificial tears, punctal occlusion, looking at different lid abnormalities, maybe a tarsorrhaphy. And then as Nick mentioned before, some of the biological tear substitutes or some of the biologics in general. So autologous serum has been shown to be very, very beneficial for these patients. Allogenic serum, amniotic membranes, and then specifically some newer options, oxybate, synedromin, the first really human nerve growth factor that's used in the ophthalmic space. And there's actually a new novel procedure called corneal neurotization, where they're actually taking a donor nerve graft and trying to reestablish or co-opt the sensation back to the cornea. And it's been shown in some early phases to be pretty beneficial.
So there's a lot of options.
Right.
We got to get that diagnosis, though.
Absolutely, and I think that's really where the key is.
Okay. Thank you both for being here. We appreciate it.
Thank you.
Thank you for the opportunity.
Appreciate
And
it.
thanks for watching Optometry TV.